Hello, my name is Marcus Weitz, and tonight we're going to talk about 15 restorative pearls to simplify implant dentistry. I want to thank Voco for sponsoring me, I practice in Cedarhurst, New York, just outside of JFK, and I want to thank my partners Barry Behrens and Dan Gober and Paul Schneider as well, who've helped me put some of the material together. We basically are periodontists who do many implants, we hooked up with Voco because through their help, their materials are really fantastic, and you'll see some of the things that we do with their materials, some on-label and some off-label, and they really help us, and they help our patients. And in our practice, the most important thing is our patients, and Voco is a good conspirator and a good helper for us. So in terms of disclosure, again, I do want to thank Voco for sponsoring. I also would like to disclose that I am involved with an implant company called Adin Implants. Adin is a spiral implant, a very aggressive spiral implant that has a standard hex connection. All across all platforms. There are multiple lines, but most of what you're going to see is going to be called the Torg S line. Adin is also available locally here in the U.S., close to my office in Cedarhurst, New York. So I do have an affiliation with them as well. 15 restorative pearls to simplify implant dentistry. If anyone wants to contact me, my email address is marcusweitz@cppc.com. A quick shout out to Nicole from Voco, who really was instrumental in putting this all together, and I can't thank her enough. So pearl number one is never let the patient go toothless. And so a lot of what we do is immediate gratification, but more important than gratifying, we try to at least preserve what's there, and you'll see some of that as well as we go forward. Here we have a patient with a very nice smile, and the patient presented with a little abscess. Let me show you where that is, right over here, and it's coming from this tooth over here, and as we move forward you'll see that that's quite an abscess, and we have quite an amount of swelling over here. It was purulent, and the patient was very, very uncomfortable. And so you can see from this radiograph over here that we have a huge radiolucent lesion. We have a tooth with a crown with endodontic treatment. I'm unsure if there's a fracture here or if there's some sort of a defect, but either way, this is a hopeless tooth that needs to come out, and we're presented with a big problem because the defect is very large. I really didn't think that we were able to extract the tooth and put an implant right in. It didn't really have time to send out for a flipper, which might be a thought, and we wanted to send this nice-looking young woman home with a tooth, and this woman demanded that she go home with a tooth. And so here's how we treated this. Here's what this looked like. The crown came off quite easily, and again, you can see over here just how full the socket is, and we're draining this little fistula, or a big fistula, that we can drain through over here. We're going to extract the tooth, and you can see this gigantic granulomatous sac, this cystic sac that came with the tooth root. And we're going to go ahead and clean the whole defect out, and make sure that we're clean. That's what that looks like. And you can see already just from that how the swelling just from pushing all of the suppurative material out is going back to normal, and our ridge form is returning to normal. And we're going to use a nice Voco product, and we'll show you in a little while how we do that using Voco bonding agent as well as Voco composite to go ahead and recreate a tooth over here. And this is what this patient is going to leave with. We did clean the area out, and we grafted the defect in order to preserve the ridge. And our patient left with a tooth. And our patient was quite pleased. And so she came in with a big abscess, instead of leaving with a big hole right in the front and needing to wait for a laboratory to fabricate something, she left with something. And she left with something, or another option that we could have considered is an Essex appliance, a suck down with a composite tooth in there, which if we were stuck we would have. But in this case we were fortunate in that we were able to provide something fixed for her to leave with. And that's what it looks like, and it's really quite an aesthetic result for not a lot of effort. And this is so good that we're going to use our provisional as a stent to go ahead and place our implant in. And so we're going to allow some time for healing, 12 weeks in this case. And I am going to show you this in a little video in a little while. And we're going to create a small little stent over here in order for us to use as a guide to place our implant. And so we're just going to take a nice crosscut burr and create a channel where we want to place our implant. And the vocal material, again, is very conducive to this. It's very easy to cut, and our bond is quite strong that our temporary stays in place, which is excellent for us. And so here we've created a small little guide, and we'll have an occlusal view in a moment. And we're going to go ahead and create an osteotomy while keeping the shell in place, virtually guaranteeing that our access is going to be dead center for our long-term result with our implants. And here we go. This is the actual placement of our implant right through the vocal composite. The Adin implant comes mounted and fixture and mountless. In this particular case, we're using a mounted version of it, and the mount is a unique design where the mount doesn't screw in, but it snaps off. So it's also very, very convenient. And this is what it looks like. And this is what our implant looks like going in place right through the composite and right through the temporary, which we've created. And you can see how our access is going to be dead center for our permanent restoration down the road. And that's what we look like afterwards. And some of the composite was removed over here or flaked off, but certainly we could see exactly where we're working. But we need to repair that before our patient leaves. And that's what it looks like with our cover screw in place. One of the really nice things about the Adin implant is that it goes in at great stability, and we'll talk about that a little bit more further in the presentation. And so almost always we place it transgingivally. In this case, we're at the level of the gingiva so that we can recreate our voco provisional and not load the implant to allow for appropriate healing. And so that's what that looks like over here. By adding some more bonding agent and flowing some more composite, we've maintained our labial profile. And that's what that looks like, and you can see how nicely we are keeping the implant in an unloaded state for appropriate healing. And that's what it looks like on the labial, and we'll show you how we do that using a unique product partnering with Voco called U-Veneer, which helps us do that. And you'll have a little quick look at that in a moment. And another pearl is to keep it stupid, is to keep it simple. Keep it simple, stupid, the KISS rule. And so when rebuilding, we're going to rebuild the original provisional so that our patient leaves aesthetically. Backtracking a little bit, you can see over here our implant is placed. We showed you already how we placed that right through the implant. You can see our graft area, which is healing. We put our healing abutment on so we're at the level of the gingiva. And here's what it looks like 3 months later when we're ready to uncover. And you can see how we're integrated, we've healed, and we're getting ready to restore. And so what I'd like to do is just show you a short video that takes you through this process from beginning to end. One of the really nice things that I wanted to show you is that the Voco composite does come in many shades. I know that passed already, but the Voco composite comes in an array of different shades, which aesthetically makes it very pleasing and very easy to use as well. Over here we're using our handpiece as I showed you in the slides before, and what I didn't show you is that we're going to prepare the tooth a little bit for added bonding. We had an MO filling on that tooth, so we're going to remove that and rebond that. We're going to etch the area once we've removed a little bit of the mesial composite. And we're going to use the Voco bonding agent, which is dual cure, so it is self-cure as well as us curing it, and it's really easy to use. I don't believe that you need to etch. I usually do etch anyway, but I don't believe that you need to. I didn't talk during the presentation about another Voco material called Grantech. Grantech is a fiber material that's embedded with a bonding agent and composite. So it's very, very easy to use, and I'm going to show you how to use it right now. It comes packaged very nicely, and what we're going to do is we're going to take it out, we're going to cut it in the carrier to size it. We're going to simply place it into the spot and cure it, and it's going to serve as a matrix for our composites that we can just flow right around it. Over here we're cutting it. What's really nice about the Grantech material is that it's very rigid, and it provides a very, very nice matrix, and it does make it very, very easy to establish and fabricate the composite provisional afterwards without really having to struggle with the composite flowing all over. There are different materials from Voco that give you a choice of viscosity as well, but the Grantech material makes it very, very easy. And so this was the first temporary that we made, and we hadn't yet used the Uveneer material. What I'm doing is I'm using a high-speed carbide burr to shape and polish my my potential restoration, my potential provisional composite restoration. And I'm going to use some polishing discs in order to polish that and bring it to a high shine. And of course, we'll talk a little bit more about occlusion a little bit later, but it's important to check our occlusion to make sure that we don't have any eccentric contacts or any high spots, because we are holding in this pontic simply by bonding it to the adjacent teeth. And it would be very, very easy and foolish to have it chip because our occlusion was off. as we discussed before, what we're doing over here is we're beginning to create an access hole to place the implant through the composite provisional which we made, and use that as a guide. I keep on talking about the vocal composite. Just to reiterate the name, the vocal name is Grandiose, and it's really a wonderful material to use. Over here you can see that we're creating the osteotomy with the labial shell of the composite in place. We're going basically right through the composite and right through the stent or the guide opening which we've created. One of the really nice things about the Adin system is the Adin drills. I venture to say that they're of the best drills in the market, in that they're very sharp and they cut very cleanly and easily, and they are stepped. I'm not using the tri-step here, but they come in multiple steps, minimizing the number of osteotomies that are necessary. So really, with one drill, you can basically get to the place where you can place an implant in. And over here, we're actually placing the implant right through the opening that we made in the stent. What I'm going to show you now is the use of the Uveneer product to recreate the facial profile. And one of the really nice things about it, especially with the Voco Grandiose material, is that it ends up after cure naturally with a very nice luster and a very nice shine. And so what we're going to do is we're going to fit the shell, the Uveneer shell, right over the tooth. After preparing the remaining composite with bonding agent, we're going to fill the shell with some more composite. We're going to place the shell in place and cure it. And what we're going to end up with, really with minimal effort, is a beautiful, beautiful restoration as a combination of the Uveneer with the Voco material. I want to thank Dr. Gober, who was really instrumental in helping me with the video material. What I'd like to do is to review, and let's look at one more case. I'm not going to stop. We'll just run it through from beginning to end. It's a different case, but again, very similar, with very similar materials, where we're using the composite, the Grantech, the Uveneer, and you'll see what kind of an amazing result we end up with. Okay, again, let's look at the next pearl. Have it your way. Have it your way means that sometimes nature does it best, and why mess with nature? Why replicate a good thing? So I'd like to introduce you to my friend Chuck. And what we're going to do over here is we're going to replace these incisors down here, and you can see how twisted they are. And so certainly in the final restoration, the general dentist is going to replace them and try to make them nice and straight. But in the provisional restoration, we're going to try to keep them exactly the way they are. And so there are various techniques for doing this, either by immediately loading implants, which we can show you a little bit later. What we decided to do here is more along the theme of what I showed you already with the Grantech and the Grandiose Composite, only this time we're going to keep the teeth and bond them in place. And so what we're going to do is we're going to use Restorative bite registration, which is a very rigid, extra hard, and quick set registration. We're going to flow that in, and what we're going to do is we're going to use that as an index, and that's going to help us to replace our teeth. And you can see what that looks like. We're going to trim it back a little bit once it sets, and it does set quite quickly, and that's what it looks like. And so it's very easy, very quick, something that you can do tomorrow in your office chair side. And then we're going to go ahead and extract those two teeth. Again, our treatment plan is to replace all four of them. We're going to extract those two teeth, and that's what that area looks like. We're going to take out those extracted teeth, and we're going to use the actual crowns as a provisional by bonding them back in place. So what we've done is we've extracted the teeth. Over here you can see, back in the lab we're going to cut them, and we're going to add a little bit of bonding agent on the cervical end, and we're going to polish it to a high shine so that everything heals nicely without trapping any food. We're going to go ahead and again use the Grandiose and Voco and a little bit of Grantech. We're going to etch them, cure them. What you can see we're doing over here is we're placing our implants right into the osteotomies. Again, the Adin implants are beautiful implants to use for immediately loaded situations. They're spiral implants, and so they go in at very, very high torque, at very good stability, and they also allow you the opportunity of changing direction as you're placing them, so that you can almost guarantee that you're going to end up with the access holes in the correct positions. And we can talk about that a little bit later. But over here you can see just how we ended up. Very nice, very parallel, with the access holes exactly where we would need them for the final restorations, should we want to go screw retained. What we're going to do is we're going to use our index, which we created just moments earlier with the Restorative material, and we're going to reseat those teeth which we cut right back into that index, take that index and reseat it back onto the teeth. Over here we're going to etch the teeth ahead of time, and we're going to use the bonding agent on them. We're going to go ahead and put these back here, and what we're going to do is we're going to use a little bit of bonding agent and a little bit of Grandiose Composite, Vocal Grandiose Composite, just to tack them in place and hold them. And basically what we've done is we've recreated exactly what nature gave us, which is the teeth in the exact position, so that our patient can go home with exactly what they came with. And that's what it looks like. You can see over here how we cut them down enough so that we're not loading our implants, and we're going to let those heal in an unloaded state. And that's what we mean by take a load off. And that's another pearl which is really important to control the forces with implants. We're going to show you a little bit later how we immediately load implants. But for the most part, implants we know need to heal in a non-loaded state. The nice thing about the Adin implants also is that they do come in varying surfaces. We usually wait between 8 and 12 weeks. I usually wait around 12 weeks, but studies clearly show that we can wait shorter, even 6 weeks at some points. I am going to show you in a little bit some immediately loads, which is something that we really do very, very much of. In my own office, we probably do immediately loads, not probably, we do immediately loads every single day. And I can honestly say that not a day goes by that we don't have an immediately load or treatment plan and immediately load, many days, multiple ones. Again, we're going to use the Grantech material with the Grandiose. In this case, we're going to use heavy flow. We've already tacked it down with the flowable composite. You can see what the Grandiose looks like over here. We're going to tack it in place. We're going to cure it as we showed you before on the video, and it's going to act as a matrix. So that we can go ahead and add some composite very easily, very quickly, very nice, easy to polish. We're going to make the area cleansable. We're going to stay away from our implants so that they heal in an unloaded space, in an unloaded area. And over here, that's what it looks like. And our patient's going to go home very happy because they're going to go home with exactly what they came with during the healing period. Again, our long-term goal here is that we are going to extract these two teeth, and we're going to replace this with an implant-supported bridge on these two terminal implants on either side. And again, you can see how nicely this polishes and how nicely this looks. It's all about the bite, and I talked a little bit before about how important it is to control the bite. Here is another pearl, which is just to use petroleum jelly on your articulating paper before you go ahead and take your bite. Simply by putting a little bit of Vaseline on the articulating paper, when you go ahead to take your bite, what you're going to get is very, very nice, very, very strong marks, which are very, very easy to adjust. And that's a pearl that I really would suggest, if nothing else, that anyone who's logged on go home, and if you haven't done it already, that you try it tomorrow. Really very, very easy. Whenever you're looking to adjust bite, a little bit of Vaseline painted right onto the articulating paper. It'll make your life so much easier. For years and years and years, until I was shown this trick, I would struggle. I'd use thin articulating paper, I'd use thick articulating paper, and I could never see the dots. Right now, we just use this Vaseline, we have them bite, and you could see very clearly how the dots are. When checking occlusion, if you use two-sided articulating paper, another pearl, which I just learned this week from my colleague Dr. Muckamal, is that you can have them bite down and you'll pick up the opposing colors. So when you're using red and blue articulating paper, you can do this, go chomp, 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 take the articulating paper down and have them bite, and you'll pick up the opposing marks exactly where you're hitting. It's all about the smile. So we also talked about not going toothless, but let's switch over to a new pearl. And people come, and they don't come to my office asking for implants. People come to my office because they want to smile nicely, they want to retain form, they want to retain function, they want to speak nicely. And so in this particular case, which we're going to walk you through, we're going to do an immediately load. And you can see that this is a tooth which was a hopeless tooth, which we'll see in a few minutes. And this is what the provisional restoration looks like. Quite a feat in restorative provisionalization, but really quite easy once you master the steps and use the appropriate materials. And so amazing to be able to achieve this on a predictable basis in a routine way every day. Let's see how we do it. So why reinvent the wheel? The best provisional would be the tooth itself. So if we could extract this tooth and save it, of course, that would be the very, very best way. We already showed you how to do that in a non-implant environment using the Restorative as an index. In this particular case, here's our tooth, and we have a hopeless tooth over here, and you can see the resorptive process that we have over here. You can see the slight widening of the lamina dura, and we had some mobility. Very uncomfortable for the patient, and so we elected to extract this tooth and replace it. So how are we going to get from point A to point B, knowing that we're going to place a provisional? Well, the first step is atraumatic extraction. So we're not going to show you that right now in here, but it's important to know that we're going to spend some time with the extraction. We're going to rotate, making sure that we maintain our buccal plate, whatever buccal plate or bone we have. We're going to use very fine instruments called a periotome to slide in between the tooth and the periodontal ligament to loosen it so that we can maintain our socket. and maintain our buccal plate without removing any bone. And you can see just how nicely this looks. This is 15 or 20 seconds post-extraction. You can see that we've controlled the bleeding, but we've retained our tissues exactly where they are. And once we've retained them, now we have the difficult task of maintaining them. You can see how hard it is with our peaks, our gingival peaks, our papilla, and our job is to keep that so that ultimately the final restoration can mimic it, and we can give our patient what they want, which is something that nobody knows, their own natural teeth. We're going to go ahead and place our implant into our socket. Again, we're using an Adin Toric S, a long implant. You can see how well it's placed right into the socket, emerging in a very, very nice place. Over here, we are emerging slightly buccal on purpose. We're going to use a cementable restoration using a novel abutment, which is available through Adin, which allows you to create an immediately cementable restorative solution that allows you to create a crown which we can cement on with very nice contours very easily, very quickly. And it's called a pick pack, and we'll show that to you in a few minutes. And so that's what our implant looks like. And when looking at these x-rays, it's important to realize that our implant needs to be placed not at the height of our interproximal bone, but our implant needs to be placed where our buccal and palatal plates are, so that we don't get recession and show metal, especially on the buccal plate. And so that's where we are over here. The Adin implant, as I mentioned, is a spiral implant. It goes in a very, very high torque, which is very conducive to immediately loading, very, very conducive to immediate restoration. For the purposes of our lecture tonight, we're going to show many single teeth, but we do use it for full arch immediately load restoration as well. All on 4s, all on 6s. In our office, we actually restore with porcelain cases inside of 2 days. So we extract teeth, immediately place implants, and work with very closely with some very, very talented people, both in-house and out-of-house, who are able to fabricate porcelain, zirconia, one-piece restorations that screw down for immediately loaded restorations. But over here you can see we're placed at very high torque in a very nice place. You can see the intimate contact we have with our bone. And we're going to take our tooth that we extracted, and again, just as in the bonded case that we showed you before, we're going to preserve it, we're going to cut it down, we're going to take the post out, we're going to totally clean this area. It's, in my opinion, imperative that we use a sandblaster and we use a micro etcher, and we're going to totally clean that area out. This is the pick pack we were talking about. It's a provisional abutment kit, which is available from Chattel Industries in New York. They distribute Adin, and their number is the Adin number. And you can see that it basically comes with 3 components in it. It comes with an abutment which screws in, and this can be screwed in one of 2 ways. It can be, there is a screwdriver which Adin makes, and it's the same connection as the old standard abutment. And what that does is it goes over the outside of it, and so you can grab the whole thing. It's basically a thick screwdriver. I don't have a picture of it today, but it's a thick screwdriver with a hex cut out in the middle, which basically goes over this part right over here, and you can just pick this up and twist it in. This abutment also comes with a standard hex, which in the case of Adin implants is an 050 hex, milled right into the middle of it, so we can use that to screw in. It comes with a PMMA shell, which is a polymethyl methacrylate shell as well, and this shell is milled so that it fits intimately over the hex, and it's very easy to reline with acrylic or with other material called Restorative. Not Restorative, I'm sorry, Restorative is the pickup, with another material which is a very, very quick setting composite material that we can use to realign a temp, and we'll show you that in a little bit. And it also comes with an analog to help the laboratory fabrication to make a quick provisional. And so here we are with our implant in place and our abutment in place, and over here you can see that there's a hex, and the hex serves for placement using the tool that goes around the hex, but more importantly the hex serves for retention for this little sleeve that just fits right over it. And there is another hex. This is the outer hex. There's another hex which is milled in, which the standard 050 screwdriver fits into for placement. We do need to block this out. I believe in the second generation of this abutment, it will come with this already blocked out, so the PMMA will close it. But for the time being, we need to block it out. We're going to use some Teflon, and that's going to be another pro, which we're going to show you in a few minutes. We're going to go ahead and etch our crown. We're going to use the vocal bonding agent, and it is dual cure, so we're going to cure it. Again, we're going to use a shell just like we did before, and what we've done is we've filled it. We're going to reseat it right back into the shell, and over here we have our nice restorative material, and you can see what that looks like. We're going to remove it, and that's what it looks like inside the shell. We're going to put it onto the analog, and this is what it looks like on an analog, and then we can take this back to the lab, and very, very quickly we can polish this and achieve ideal contours. And it's important that we do fabricate it and maintain these ideal contours. You can see over here that this material is called structure, as we mentioned before, but you can see over here that we've maintained the part of the tooth both that we see clinically, and in this particular case we couldn't, but if we could have maintained the part of the tooth that actually sits on top of the gingiva, we would have. Over here we're recreating that part of the tooth to support our gingival collar as well, and that's going to be important in controlling recession as we heal. But you can see how we've achieved very, very nice contours, and you can see how nice and high polished they are. And over here, this just goes back and it cements right in, and it's a cementable restoration. Again, it's important for the immediately load restorations that we control our occlusion. You can see how we've taken all occlusion off of our tooth, and that's what it looks like immediately post-surgery. This whole procedure from start to finish, believe it or not, takes about an hour and a half. And that includes all the anesthesia. It includes getting the patient numb. It includes placing the implant. Again, we're not flapping. We're going right into the socket. It includes grafting the socket, and it includes recreating the provisional. So it's really a terrific service, which you can be reimbursed for quite nicely. You can see that aesthetically we're really achieving an amazing feat using our natural tooth. And in the long run, we're also creating an aesthetic feat by maintaining our gingiva and maintaining our papilla in a way that only nature can. And that's what it looks like on radiograph, and it takes some time to get used to that, and that's what we look like. And that's what we look like at Uncovery several months later, and you can see that we've achieved everything that we've set out to do in terms of maintaining our papilla and maintaining our contours and maintaining our aesthetics. And what we've returned to the restorative dentist is a tooth that's ready for restoration in a very, very nice way. And again, that's what we look like. For a stable future, it's important that we speak a little bit about stability. And so what I'm going to show you again is a similar case. In this case, we have two maxillary laterals which we're going to be restoring. We're going to take a preoperative CAT scan to make sure we have enough bone, and it does appear like we have plenty of bone. You can see over here on our CAT scan that that we do have adequate thickness. And we're going to go ahead and we're going to do this flaplessly. We're going to use punches, and we're going to go right through the punch, again using our dent implant going in. This is what it looks like mounted, and so this mount, once it goes in, just snaps right off. And here we are our implants placed. Very interesting that when we're placing implants on young people, we have to anticipate some future recession. And so I usually use the CEJs of the adjacent teeth as a guide. Again, some room for bone that's going to support our papilla. And that's what our two implants look like. And this is our torque wrench that we use to place the implants, and I do place the implants by hand. There is a driver, so you can, with the Adin system, place them with the implant driver, with the implant machine as well. It's hard to see over here, but we are going in at 90 Newton centimeters of torque. And again, it's not for the purposes of this presentation, but we can talk about torque, and we can talk about initial stability and its relationship to torque, and its relationship to a biologic stability and its relationship to immediately loading. But needless to say, it's important that we have very, very high stability. Certainly, we don't need 90 newtons, but we need upwards of 30 or 35 newtons. But the 90 newtons only gives us more confidence and only helps so that we can place these and restore them immediately. And what we're going to do over here is very similarly, we're going to restore them immediately using the pick pack from Shetel and Adin, only this time we're going to use ion crowns, and we're going to reline them, picking up the PMMA, taking it back to the laboratory, adding some acrylic, polishing it back, getting our very nice contours, cementing it in, adjusting our bite, and that's what our patient goes home looking like day of. And you can see again what a nice result it is for this very lovely 16-year-old girl. And that's what it looks like radiographically. And I believe that these are post-op x-rays. So we have a little 1 millimeter lip. You can see our platform switch over here. And we have our very, very nice restorations. And this is what it looks like 3 months later. And you can see the really very, very beautiful contours, papilla we've created. Over here we didn't have the papilla, but we've created the papilla with our provisional restorations. And we're all ready for permanent restorations in this case. Here's another pearl, again, something to take home tomorrow, using bacitracin ointment on your abutments. And very often you'll know that when you take the healing abutments off, there's a terrible odor or a terrible stench. What we do when we place these is we put a little bit of ointment on the very, very tippy tip, and we screw it in. And not only does it make for easier retrieval, but it does take care of all the bacteria that are there. And so when we remove these, our sites look healthy and they smell nice, and we don't have some of the issues that we had before. So again, some ointment on the cover screws or healing abutments, a very, very big help. Let's talk a little bit about structure and getting screwed. So the cases that I showed you before, I believe now in hindsight that I erroneously told you that that first case was structure. It may have been just the regular jet acrylic, but let's go through a case using structure 3, which is another vocal material. It's a temporary material, and we'll see how nicely this is. So over here we have a tooth that we're going to be extracting, and you can see we have a hopeless tooth, and this is what it looks like preoperatively. We're going to go ahead and place this this implant after extraction. You can see we're going to atraumatically extract this tooth. We're going to make sure that we maintain our labial contours. What I've showed you so far are immediately loaded implants, which we've restored with a cementable immediately loaded restoration. In this case, we're going to restore it with a screw-retained restoration, and we are trending more and more towards that screw-retained restoration. When we place these, we're always going to try to cheat a little bit palatally, because we need to leave room for the bulk of our screw. And certainly we're going to try to access our screw access dead center. And so here we are, and we're placed, and you can see how we're placed. We have plenty of room buccally in the room of our buccal root, and so we went into our palatal root over here, leaning towards the center septum. So we're really basically in the interproximal, in the interradicular bone, but we are leaning towards the posterior. We're placing a nice long Adin implant again, going in at very, very high stability. We're going to take a very nice prefabricated plastic tube, We're going to cut some grooves in it for some added retention. Over here we have an ion crown, and we're going to create that as well with an access so that we can access right through the center, and I'm going to show you that as well. Once I assemble it, and I'll show you that as well. So here it is with the plastic tube in place. We're going to use a long pin through the middle of it so that it comes out the occlusal surface. And you can see how we're placed just slightly palatally. In a mesiodistal way, we're placed really perfectly. It's important that you try your ion crown in ahead of time. I don't have a picture of that, but over here we're going to use Structure 3, which is a very, very nice material. It's an auto mix cartridge system, so we're going to use our gun, and really without much play in the office, we're going to inject it right into our ion crown. You see over here that I'm going to hold the outside of it with my finger, because as I showed you before, I had a hole right through the middle, so I don't want it all oozing out. So I'm going to squirt it right in there, and I'm going to seat it right through my tube, and you can see how I'm seating it over here. I need to use the long guide pin so that it comes through. I'm going to use my fingers and small instrument while it's still soft, just to remove all the excess, and you can see what that looks like over here. And we're going to clean that all through, and I'm going to remove that, and that's pretty much what it looks like when we're removing it. And I know this looks like they're occlusal marks, but I think they're just some excess heme into the voids that we have. And so very, very quickly, really inside of a few minutes, it sets very hard very quickly. The Structure 3 is very, very easy to use, and when we remove it, this is exactly what we have. And so I have my tube. This part was in the implant. I removed it, and I have a very, very nice form using an ion crown already, almost ready to recreate my tooth. And that's what it looks like cemented, and that's what it looks like screw retained a little bit later. This is with the shorter guide pin, but I'm going to show you how we got there. We're going to take that out of the mouth. We're going to assemble it on a standard analog now. So there's no kit over here where it comes packaged. But we're going to use the prefabricated plastic. We're going to use a standard analog. And the nice thing about the DIN implant is that regardless of what platform implant you're using the Torgas system, it's the same platform. It's a standard internal hex connection that is the same analog, so you really don't need to stock very many pieces in your office. And we're going to put that together, and that's what it looks like. And once we reassemble it, we're going to change tips on our gun, and we're going to use some Structure 3 and very, very carefully flow it through to fill in any of the voids, both occlusally and cervically around the base of our implant, and that's what it looks like. I'm going to go ahead and take that guide pin out. I'm going to use a regular short holding screw, and I'm going to put it in, and then in the laboratory I'm going to very, very quickly polish it up, and that's what it looks like polished up. Again, I'm going to recreate my contours, make sure here my buccal contour I've maintained. As I explained before, I'm cheating towards the palate, but I am going to exit dead center, and I think I showed you that clinically before, where I'm exiting dead center, right, just like that. That's my lingual contour, and that's what it looks like in the laboratory. And now, very, very nicely, I'm going to place that right in. I'm going to graft my buccal socket with some bone, and that's going to help us maintain our buccal contours and our buccal socket as we heal. I'm going to place my temporary that we very, very quickly fabricated in, and that's what it's going to look like. That's what the buckle's going to look like. Here's another pearl, which I'm going to show you in a little while, which is we're going to use some Teflon. Instead of using cotton in, we used some Teflon tape. Again, this is also available from Chettel Industries DIN implants, and we're going to pack this into the hole. And the real big benefit of the Teflon tape is that you can nick it with a drill, so you can be very aggressive, very easy to remove it, and it's going to come out in one piece. And I have a little video of that as well to show you. So it's a very, very nice adjunct. It's very, very easy. Anyone who does practice implant dentistry who's gone ahead afterwards to retrieve these knows that first, if there's no cotton, it's a fiasco, and if there is cotton, then very often it's a headache. we've toyed with all kinds of different products which you could use, polyvinyl rubber that you could squirt in. But the very nice thing about using the Teflon is that we can get a very nice aesthetic seal of the hole using either Fermit or composite. Or in this particular case, we can just use the actual structure material, and it'll be the exact same color. And we know that we can just aggressively pick up the drill and go through it because we have the Teflon buffer on top of the screw. And here's another pearl, which is the very, very nice things about the screw is that it is retrievable. Again, let's look at the Teflon tape, and that's what that looks like. And I showed you very quickly what that looks like. Here it is. We're going to cut a little piece of Teflon. We're going to pack it in. And so let's look at another case with the Teflon and see what that looks like. And so again, I'd like to thank Dr. Gober for his help with the videos. Just to review some contact info, if anyone wants to contact me or those that have sponsored us through this presentation, I'm available through email anytime. I did list my office phone. If anyone has any questions, I'll certainly try to get back, but email is the best way to get hold of me if you have any questions. I've also listed contact info for Dent Implants, which is 212-764-2900, and I thank them. And for Voco, I guess your local distributor is probably the best. They can be reached at 888-658-2584. And again, I thank them for sponsoring me, but more importantly, for the great materials that really make our job so much easier and so much better and so much more predictable for us, so that we can give our patients what we set out to do. And again, a quick shout out to Nicole from Voco, who really facilitated this webinar and helped us get to where we are.